In this lecture, we will discuss the EKG progression from myocardial ischemia to myocardial infarction. Myocardial ischemia and infarction typically show STT changes and QRS changes, respectively. If you recall, we said that generally speaking, ischemia tends to affect repolarization and thus the ST segment and T wave. On the other hand, infarction tends to affect depolarization and thus the QRS complex. So let's take a look at the progression of the EKG changes from before atherothrombosis and occlusion to ischemia to infarction and to the post-infarction period. We will be focusing on the QRS complex, the ST segment, and the T wave. Okay, so imagine that we have a 65-year-old gentleman with a history of hypertension and coronary artery disease that presents with episodic chest pain on exertion. Already, we are getting a feeling that this isn't looking great for him. But we look at his EKG and it appears normal. That is, there are no ischemic changes on the EKG. So if you look here, our patient comes in having these episodic chest pain episodes, okay, on exertion, but notice that before any occlusion occurs, we have a normal EKG. No ST deviation, normal upright T wave, no QRS changes. Okay, so everything is normal on the EKG. And then suddenly he develops chest pain radiating to the left jaw and the left arm, along with some nausea, vomiting, okay, and some weakness. At this point, atherothrombosis and coronary artery occlusion have just occurred. And from this point forward, imagine that we have him continuously monitored to look for and at the progression of the EKG changes. Now, early on, during the hyperacute phase or seconds after the occlusion, his EKG shows hyperacute T waves. These generally persist for only a few minutes and therefore are not commonly captured and seen. There is something called De Winter's sign in which the hyperacute waves actually persist, but we won't get into that here. We'll use that in another lecture. Okay, so what we have going on here are occlusion, okay, that chest pain comes on, he has this coronary artery occlusion, and immediately seconds after we have this hyperacute phase in which these T waves start peaking. Okay, so notice that our T wave starts peaking. That's very large, okay, broad based, and that's what we see going on. So that's one of the first changes. Remember, it's so early that we often don't see it because they actually don't even last too long. Okay, now in the next minutes to hours after the occlusion, the hyperacute T waves diminish and the ST segment becomes elevated. Okay, now we're in the acute phase, so minutes to hours later, what we have going on is now our ST segment is going up. Okay, so now we have ST segment elevation, okay, and our T waves that were up here start to diminish a little bit. Okay, so that's the acute phase, minutes to hours later. All right, in the next minutes to hours after the occlusion, okay, what we have going on, and this is usually about 16 hours after occlusion, we have pathological Q waves that appear, and the ST segment elevations begin to normalize. Okay, and you can think of the Q waves pulling the ST segment down if that helps to remember it. Okay, so now we're in that subacute, and this is the first hours, usually about 6 to 16 hours. Okay, and what we have going on here is now we have the ST segment elevation, but now it's coming back down. It's starting to normalize. Okay, so we went from elevated, and now it's coming back down, and imagine as it's coming back down, we're starting to see changes in our QRS complex, where these Q waves are developing. Okay, notice that's going on here. So this is that subacute phase. Okay. Now afterwards, but still within the first 24 hours, the ST segment elevations continue to normalize, and the Q waves tend to become even deeper. At this point, T wave inversion starts to appear. So again, we have our Q waves that can get deeper. Okay, we have our ST elevation that's starting to again come back down. Okay, notice how it was up at this point, okay, then to this point, and it's slowly coming down. But the main thing here also is that we're getting these T wave inversions. Okay, the T wave starting to become inverted at this point within those first 24 hours. Now, days to week after the inciting event, the patient is now stable, with his EKG showing pathological Q waves and inverted T waves remaining. Okay, so stable days to weeks later. Okay, Q waves are present that are pathological, not normal Q waves, and we also have these T wave inversions that are occurring, okay? And the ST segment is back to our baseline, okay? So T wave inversion and pathological Q waves present there. Now the inverted T waves may normalize within a few weeks, but oftentimes they'll persist longer and may become even permanent. The Q waves are typically permanent, but may at times normalize within a year or so. If they go longer than a year, then we call those chronic T wave inversions, okay? So in that chronic phase, usually months to years, they'll come back upright, okay? So we go from T wave inversion, okay? And eventually the T waves will become upright. But notice that our Q wave is still remaining there. So hopefully that makes sense. Now there are other EKG changes that we can see, but we won't get into all those details here. Briefly, some of those changes include pathological R wave progression, U wave changes, an increase in the QTC interval, a decrease in the R wave amplitude, fragmented or notched QRS complexes, as well as new conduction defects can occur. At this point, I want you to understand the basic EKG progression during ischemia and to notice how these predictable changes can give us an idea to when the inciting event took place. All right, let's review this progression one more time before we end. So again, our patient comes in, has this episodic chest pain, and we look at his EKG and everything's normal. Normal ST segment, normal T wave, okay? Then all of a sudden, the nurse comes to get you and you have this occlusion going on, okay? Occlusion comes here at this point, and you have this acute ischemic event, and because of that we see these hyperacute T waves occurring seconds after the occlusion, okay? And these are our hyperacute T waves. Notice how they're very large, they're broad based, okay? And what we have going on here, our ST segment still at baseline. Okay, and because of this, remember, this happens seconds after, but not only that, they also disappear within minutes. So oftentimes, if you're not actually monitoring the patient, you may actually miss them. Okay, so next, we have minutes to hours later in which we have this ST elevation occurring. Okay, so now the ST segment goes up, and the T waves start to diminish a little bit, okay? And then this is the acute phase. Then we have the subacute phase, which is in the first hours, okay? And notice here we have the Q waves that are forming, the ST segments coming back down, okay, starting to normalize again, but it's these Q waves that are new occurring here. All right, within the first 24 hours, that post acute phase, we have Q waves that continue to deepen. All right, so we're getting those pathological Q waves, we're getting the ST segment continuing to normalize, and now we're having T wave inversion occurring, okay? So that's within the first 24 hours, and usually the patient will come in somewhere between that time frame. Now, days to weeks later, you may have that T wave inversion that persists, okay, as well as these Q waves that are always present, are still present, okay? Those are our pathological Q waves. And in the chronic phase, the Q waves are still there, and they can help us indicate and localize where the infarction is actually located. And then the T waves may either remain inverted or oftentimes will come back and to the upright position, okay? And again, if the T wave inversions last longer than a year, we call those chronic, okay? Remember, that's where we get that post-ischemic T wave inversion, okay? Notice that's occurring after the infarction, okay? Our Q waves are appearing, okay? So we have changes in our QRS complex, and we have these T waves inverted, okay? Those are the post-ischemic T wave inversions that we discussed earlier. Well, that's the end of this lecture. We discussed the EKG progression from myocardial ischemia to infarction. I hope you learned something.